Chapter 5 and Chapter 17, Mental Status and Neurological System. Mental status is a person's emotional and cognitive functioning. The optimal functioning aims towards simultaneous life satisfaction in work, caring relationships, and within the self. Usually, mental status does strike a balance between good and bad days and allows a person to function socially and occupationally. When, though, is a mental status examination necessary? It's usually necessary in patients who have medically unexplained physical symptoms. More than half have had depression or anxiety disorders. When there are multiple physical or somatic symptoms, or a lot of system or high system count, when they present with high severity of a presenting somatic system, when they have chronic pain, which can also lead to psychological emotional disorders, when they have symptoms for more than 6 weeks, when the physician finds the encounter with the patient as rather difficult, where they can't seem to elicit any information from the patient, when the patient has maybe experienced a recent stress or a loss of a loved one, when the patient sees themselves as having low self-esteem or having a low self-rating of their overall health, when they frequently use healthcare services. That's another reason why you'd want to maybe conduct a more thorough mental health screening. And then when a patient has a history of substance abuse or use. High-yield screening outcomes for office visits. For depression, questions for depression include, over the past 2 weeks, have you felt down, depressed, or hopeless? Or over the past 2 weeks, have you felt little interest? Have you lost pleasure? High-yield screening questions for anxiety, which could also include generalized anxiety disorder, social phobia, panic disorder, and post-traumatic stress, include, over the past 2 or 4 weeks, have you felt nervous, anxious? Have you been unable to stop or control worrying? Have you had anxiety attacks or panic attacks, or maybe sudden feeling of fear? Substance-related and addictive disorders, you would use the CAGE questionnaire, which is found in Chapter 3 on page 97 of your Bates book. And multidimensional issues, multidimensional high screening questions, if they present with more than one type of symptomology, depression plus anxiety, or including substance abuse, you'd want to do a prime MD or primary care evaluation mental disorder. And that really assesses for the 5 most common disorders: depression, anxiety, alcohol, somatoform, as well as eating disorders. And it's a 26-item patient questionnaire, and it takes about 10 minutes. And usually mental status assessments or mental health screenings are very time consuming and expensive. So it's important to take it on as a 2-tiered approach, where you're doing an initial brief screening to see how the patient is doing, if there are any issues, and then follow that up. If it's positive, follow that up with more of like the high sensitivity and specificity questions, asking the patients about how they felt over the past 2 weeks or 4 weeks, or if there have been any changes. You'd also want to conduct a full mental status exam on patients whose family members see that they are exhibiting signs of memory loss or inappropriate interactions. If there's a suspicion of maybe a brain lesion, which is changing their overall affect, or if there's a known brain lesion caused by trauma, tumor, or stroke. If they're starting to exhibit any impairments in hearing or language, or if they have a past medical history of a psychiatric mental disorder. When conducting a mental status examination, you want to take more of a systematic approach to how you're asking the questions, and you want to keep in mind the four letters A, B, C, and T. You're including appearance, you're including behavior, you're including cognition, and you're including their thought processes when you're assessing their mental status assessment. With regards to appearance, questions range from how do they present to you? Are they wearing appropriate attire for the day? Are they disheveled? Do they appear happy? Do they appear sad? What is their demeanor like? With regards to behavior, it's more of a question of how are they acting? How are they acting in front of you? How are they acting with other people who might be in the room? What is their behavior when you're asking them a question? What is their affect towards a question? What is their mood like? What is their language like? When you are assessing the patient's cognition, you're asking them certain questions and you're assessing. So, for example, you can ask them to repeat a couple of words. You can tell them a couple of words and then have them try to repeat those words in a couple of minutes to determine what their level of cognition is like. If there is elements of memory loss within that. You are also assessing their thought processes by way of judgment and insight, distinguishing between what might be daydreams versus what might be hallucinations versus what's real. Or their judgment, where you're comparing and evaluating alternatives when deciding on a course of action. For example, if they are driving their car on the highway and there's a cop car with their lights blaring behind them, what is their judgment? Should they continue to speed along, or what is their judgment to do with that in that situation? Are they going to pull over as they should? So you're assessing all of these. Your Bates book on page 154 and 155 actually go through a lot of these areas of level of consciousness to determine what their mental status assessment is like. Mental status cannot be scrutinized directly like the characteristics of skin or heart. You really have to look at the bigger picture, the clinical picture, and taking into consideration their level of consciousness. Are they awake? Are they alert? Are they oriented? What is their language like? Is there a language barrier? What is their mood or affect like? And that has to do with, have they had a recent stressor in the past, such as a death of a loved one that's been impacting their mood or the way they've been they're able to approach things. What is their orientation? Do they know where they are? Do they know what time of the day it is? Do they know who the president is? What is their attention capacity like? Are they focused on who you are and what you're asking them? Or is their attention deflected somewhere else? What is their memory like? What is their short-term memory versus what is their long-term memory? What's their abstract reasoning? If you give them a phrase, do they understand what it means? For example, apples and oranges, are they the same? And abstractly, you can think of apples and oranges as being two different types of fruit, and thinking about that in a concrete manner. But abstractly, you can kind of recognize that two things, although they're the same as fruits, they're really not the same in general. What's their thought process, thought content, and their perception like? With regards to structure and function of the nervous system, again, going back to your anatomy and physiology book, review the central nervous system as well as the peripheral nervous system. We will be assessing the nervous system by way of assessing all the cranial nerves and spinal nerves. We'll be assessing sensory receptors, or the sensory messages that are carried on to the central nervous system, as well as motor receptors by way of the central nervous system. Questions that we want to ask patients with regards to their neurological assessment have to do with questions about headaches. Do they get headaches? How frequent are their headaches? When do they start? Where is the headache located? Head injury. Have they had a recent head injury? If they've had a head injury in the past, what happened? Do they have a history of a concussion? Do they play contact sports? Do they have dizziness? Have they had a history of dizziness? Do they have seizures? Do they have a seizure disorder? Are they weak in any of their extremities or both? Have they had a recent stroke? Have they noticed any new weakness in their extremities? Weakness with walking, maybe in coordination, muscle weakness, numbness, tingling. That all has to do with the nervous system and how the nervous system is functioning. You might want to also ask about difficulties with speech, swallowing, maybe a history of stroke or meningitis or inflammation of the meninges, encephalitis, or a congenital defect or a history of alcoholism. And then also ask about whether they are or have been exposed to any environmental or occupational toxins or hazards, usually in their work environment. So when preparing to conduct a mental status and neurological assessment, you want to first start with a neurological exam on their mental status, determine if they have any loss of consciousness, what their thought processes is, what their behavior is like, and what their cognition is like. Then you'll want to go ahead and perform a neurological assessment on their patients. Um, Really looking for any symptoms related to weakness or loss of coordination, especially for those patients who have signs of neurologic dysfunction. You want to integrate steps of a neurologic exam with examination of a particular body. So, for example, when we're testing the cranial nerves, we can usually target all the cranial nerves when we're doing a full head and neck assessment. When we are assessing reflexes as part of our cranial, as part of our neurological assessment, we can do that when we're assessing the peripheral vascular system. So there are a number of things. There are a number of ways we can assess and integrate the neurological assessment and mental status assessment while we're assessing other systems. It's very similar to the skin assessment. We're assessing the skin as we're assessing all of the systems at one time. So talking about cranial nerves, again, go back to your anatomy and physiology lecture and just review all the cranial nerves. I do expect that you know all 12 nerves and their function and where they're located. In this class, you'll be expected to learn how to identify them and test to determine if they're intact. With cranial nerves, cranial nerve 1 and 2 and 3 and 4 and 5 and 6, all the cranial nerves can be kind of identified in this nice little graphic picture, which looks really like a face. And you can, if you look very carefully, you can also see there are numbers. And so this is kind of a neat and easy way to remember where all your cranial nerves are located and to know how to test for them. So cranial nerve 1 is your olfactory nerve. And that is one way to test that is to just have the client blow their nose if it's obstructed, and then have them close one of their nares, close their eyes, and have them sniff a certain substance that you will provide for them and have them try to identify what that simple substance is. And then you can repeat it, closing their eyes. You can repeat it with the other nerve. Cranial nerve 2 is the optic nerve, and that's simply tested by way of the Snellen chart, one eye, the other eye, and then maybe both eyes to determine how intact cranial nerve 2 is. Cranial nerve 3, 4, and 6 can be tested by way of the cardinal fields. So you would just do the star or the H to determine the cardinal fields of the cranial nerves. Cranial nerve 3 is also assessed by pupillary dilation and constriction. Cranial nerve 5 can be tested by having the patient close their eyes and then state every time they feel something touch their face, whether it's sharp or soft. And you can take an object, have them close their eyes, and then right at the level of the forehead, the level of the maxillary bone, and then the mandibular bone, because cranial nerve 5 cuts across the forehead, the mandible, as well as the maxillary and mandible. Touch and have them identify, number one, if they feel a sensation, and number two, to identify what type of sensation that is. Cranial nerve 7 can be tested by having the patient smile, frown, puff out their cheeks, and you're really looking for symmetry bilaterally of the face. And one of the common like lesion that can cause Bell's palsy will be a lesion right on cranial nerve 7. Cranial nerve 8 is your whisper test. So you're testing the auditory nerve or the acoustic nerve, which is cranial nerve 8. You can also test it by the Weber test, by the Rene test, but the whisper test is also one of the easier ways to test it. Cranial nerve 9 and 10 can be assessed by having the patient open their mouth and having them say ah, and you're just looking at the uvula to determine if it vibrates, and there should be symmetrical vibration of the uvula. And also just by the patient speaking, just understanding and listening to their speech, you can tell how intact those two nerves are. Cranial nerve 11, right here and here, you can have the patient shrug their shoulders, and you're just testing that one way. And then another way to test 11 is to have them stick out their tongue, and then you're putting resistance against their tongue and then having them move their tongue against resistance. I'm sorry, that's cranial nerve 12. That right there was cranial nerve 12. Cranial nerve 11 is shrugging the shoulders. Cranial nerve 12 is resistance with the tongue. So what I'd like you to do now is go to your Bates video, go to 17.4, and please view the video on how to assess cranial nerves. So in assessing the motor system, you want to first inspect before you touch. So you're going to inspect upper and lower extremity muscle groups for size and symmetry, comparing the right with the left. There should be normal size between the two. And if muscles and extremities are asymmetric, then what you would need to do is measure them in centimeters. If there is a difference of 1 centimeter or less, it's really not that significant. So a good example of that are arm muscles. Some people tend to use, if they're more dominant in the right arm, their arm muscle on the right side might be a little, stronger and larger than the muscle on the left side. So I want you to also watch Bates video 17.5 and 17.6 to identify ways to test the upper and lower extremities of the muscle system. And this is also the same as muscle strength and range of motion. Sensory pathways, again, go back to your A&P book, review the sensory pathways of the central and peripheral nervous system. Just know that your sensory pathways might take one of two routes, either your spinal thalamic or your posterior dorsal column, depending on the type of sensation. And this is a really nice picture to show you how a stimuli or a sensation is transmitted from the source to the brain and then back for interpretation. Bates video 18.3 goes over the various ways that one would assess the sensory pathway. So please go back to that video and review it. For reflexes really are a basic defense mechanism of the nervous system. It's involuntary, usually below the level of conscious control, permitting quick reactions. So a hand on a hot stove, you're quickly going to pull that extremity away. There are 4 different types of reflexes that we'll be assessing for, more common of which are your deep tendon reflexes, which you'll be assessing for upper as well as lower extremities. Your superficial reflexes that include the corneal reflex as well as the abdominal reflex. Your visceral reflex, which we've also assessed when we did an eye assessment, and then the Babinski reflex, or which would be considered pathological if they have a positive reaction. So this is just a picture of the normal natural reflex arc of what happens, which goes directly to the spinal cord and then reflexes back for immediate interpretation of the stimuli. Deep tendon reflexes, measurement of stretch reflexes reveal intactness of the reflex arc at specific spinal levels, and normal override on reflex of higher cortical levels. So it's more, like I said, it's more of like a defense mechanism of the body to prevent an extremity from lingering on a harmful source as it gets interpreted by the brain. With reflexes, you always want to compare the right and the left sides, and there should be an equal response to both sides. When we're assessing reflexes, we're assessing it on a 4-point scale, where 0 is no response at all, 1 is diminished, 2 is your average, your normal, plus 2 deep tendon reflexes, for example, 3 is pretty brisk, and then 4 is extremely brisk. Watch video 18.5 of your Bates set to identify how the reflexes are assessed. And you're going to learn how to, in lab, assess the brachioradialis, the tricep, the bicep, the patellar, as well as the Achilles, and these will be required for your final, for your midterm assessment.